Good afternoon. It's my pleasure to be starting this three-part webinar series on hepatitis C. And my name is Punni Perumal-Swamy. I am a hepatologist and gastroenterologist at the University of Michigan and Ann Arbor VA Medical Center. And I'm working with the team at the Michigan Opioid Collaborative to integrate Hep C services. And so this webinar is being conducted as part of our work with Michigan Opioid Collaborative. Today's webinar will be the first of a three-part series, and the topic today will focus on hepatitis C epidemiology and screening. So these are the disclosures. The Michigan Opioid Collaborative has funding from the Michigan Department of Health and Human Services. So the objectives of this webinar are going to be threefold. Number one, to review the epidemiology of hepatitis C in the United States. Number two, discuss hepatitis C screening and diagnosis. And number three, finally, to introduce ways the Michigan Opioid Collaborative is working to build hepatitis C provider capacity in the state of Michigan. So the focus again today will really be on screening and diagnosis. And just to give you a preview of what will be coming up in the upcoming webinars, numbers 2 and 3 will focus on pre-treatment assessment, treatment, and then post-treatment monitoring. So we'll start by trying to put this into perspective when we talk about hepatitis C and curing hepatitis C, and really the road to get here. This past year, we were fortunate to honor 3 Nobel laureates who were very integral in us getting to this point of saying we can cure nearly all patients with hepatitis C. And when we think about the treatment journey as it relates to hepatitis C virus, this goes back to the mid-1980s when treatments weren't very good. And over the years, treatments became refined. And we're now at a point where we can cure nearly all patients living with hepatitis C, thanks to these great advancements in science. And this could not have been done without the hard work of all of these scientists, the healthcare professionals involved, and the patients that really participated in all of the trials that got us to this point. So it's been a long journey, but we are in a very lucky place with hepatitis C. It's a chronic disease that we now can say we can cure. So I wanted to start with this statement from the hepatitis C guidance, which comes out of the American Association for the Study of Liver Diseases and the Infectious Disease Society of America. And this is what we consider a grade 1A recommendation. And I think it's a good starting point for this webinar series in that it states that antiviral treatment is recommended for all adults with acute or chronic hep C infection, except those with a short life expectancy that cannot be remediated by hepatitis C therapy, liver transplantation, or another directed therapy. And so with the advances in these great treatments, our approach now should be to not say, who can we treat, but rather, how do we get everybody treated? And the reason why this is important is because hepatitis C remains a major source of morbidity and mortality. The most recent estimates in the United States put hepatitis C infection at around 2.4 million persons in the United States. And when we think about other chronic liver diseases and their contribution to development of cirrhosis or advanced liver disease, including the complication of liver cancer or HCC, hepatocellular carcinoma, hepatitis C remains a major contributor to why patients die of liver disease, as well as development of cirrhosis and development of liver cancer in the United States, which just really impresses upon us why this remains an important entity for us to talk about reducing the burden, curing patients to really improve these health outcomes. So the CDA, Chronic Disease Analysis, does global estimates of hepatitis C infection. And according to their estimates, the burden of hep C infection as of a few years ago was a little higher than what I just quoted, maybe closer to 3 million persons. I think the striking thing here is that this group also is able to take data and estimate how many patients have we diagnosed and how many are we treating annually. And I think the really highlight from this slide and this data is that we estimate that less than 50% of people living with hepatitis C infection in the United States have yet been diagnosed, and less than 10% are getting treated annually. So again, I think this helps really impress upon us where we have work still to do with critical first steps of diagnosis and then moving all of these patients, if possible, to treatment. And when we look at the United States and the response to HIV as compared to hep C, we know that we've had historically a very disproportionate response. So where we've made really great strides with decreasing the prevalence of HIV infection and really reducing the number of patients who are undiagnosed with HIV, as shown in blue here on the bars in terms of infection, and then also with mortality and where we've devoted funding. Hepatitis C, in stark contrast, has had an increasing prevalence, and still too many people are undiagnosed with this infection. And many people live with this infection silently until they develop a very late stage complication. And hep C has now become a very significant contributor to mortality. And you can see how this contrasts to HIV, and yet funding for hep C, federal funding from the NIH still lags behind what we see for HIV. So when we think about the epidemic really of hepatitis C infection that we've seen, most particularly over the last 5 years, we've noticed a dramatic increase in the number of new cases of hep C infection. And this has really happened in parallel with the rise in opioid use disorder and the opioid use crisis in this country. And so these are really considered parallel syndemics or epidemics, which we'll talk a little bit about. So not only have we seen a rise in the number of new cases of hep C infection, but when we think about who's getting hep C infection, we've seen a significant increase in the number of young persons who are now being diagnosed with hepatitis C infection. So for many years, we had our eye on what we termed the baby boomers, persons born between 1945 and 1965, shouldering most of the hepatitis C infection in this country. And what we've seen over the last 10 years is this rise in people born between 1981 and 1996 in particular, when we think about hep C infection. So this is looking at the estimated rate of people living with hepatitis C, and this is data from 2013 to 2016. And this is to help try to put where we are in Michigan in comparison to the rest of the United States. And the lighter the color yellow, the lower the estimated rate of people living with hepatitis C compared to on the right side of the bar at the bottom, the deeper shades of orange highlighting higher rates of people living with hepatitis C. So you can see that Michigan is not really on either end of the spectrum, but somewhere right in the middle in terms of how much hep C we're seeing compared to the rest of the country. Now, as I just mentioned, we've had this increase in new hep C infections, and this has nearly tripled over the last 5 years. And opioid use disorder has had many unintended infectious disease-related complications. So in addition to hep C, we've seen a rise in HIV cases as well as hepatitis B, among other infectious disease-related complications. And so this concept of the syndemic has been introduced when we talk about opioid use crisis and what we're seeing with these infectious diseases, such that 2 or more afflictions can interact synergistically contributing really to an excess burden of disease. So the number of new Hep C infections, again, has nearly tripled, reaching a 15-year high. And again, greatest increases have been seen among persons, young persons between the age of 20 to 29 with injection drug use history. Now, the majority, 75% of the 2.4 million people that we estimate in the United States who are living with hepatitis C are still in that baby boomer generation, but we're seeing this dramatic increase in young persons. So this is to say that we need to probably have an eye on really both of these groups. And what we do know is that, again, the baby boomer generation really goes back to infection that was acquired for most of them starting in the 1970s and 80s. And at that time, we had over 280,000 Hep C infections a year. And that's what's led to now persons born between 1945 and 1965 still shouldering a great deal of burden of the disease. And as we age, the amount of scarring and advanced liver disease goes up, along with those complications related to morbidity and mortality. So we're now in the era of hepatitis C elimination with the approval of these direct-acting antivirals for hepatitis C that can cure nearly all patients living with hepatitis C. And because of these advances in treatment, in 2016, the World Health Organization adopted a global goal of viral hepatitis elimination by 2030. And this was later in 2018, also adopted by the US National Academy of Science, Engineering, and Medicine to help us develop and devise our national strategy in the United States. So what does elimination of hepatitis C by 2030 mean? This has been defined as a 90% reduction in new infections and 65% reduction in deaths attributable to hepatitis C. And what you can see in terms of when these targets were first initially established globally, that in order to achieve these targets, we have to really scale up diagnosis or testing and transition to treatment for those that are living with infection. So the Chronic Disease Association has also projected out how the United States is doing in terms of achieving hepatitis C elimination targets. So there have been improvements in terms of achieving diagnosis rates that would get us to achieve the elimination targets. And treatment has also increased. Unfortunately, where we're still getting outpaced is with the number of new infections or incidents of hepatitis C infection. And because of this, this really is throwing off the targets to eliminate hepatitis C in the United States by the year 2030 because of this discrepancy. Now, hepatitis C is an achievable goal, as we just said, because of these new treatments. However, there are a number of barriers to getting patients cured of hepatitis C, and people are studying and actively trying to overcome these barriers. And barriers include the high cost of this drug, first and foremost, the lack of access to specialists, which is really no longer needed in the same way that it was when treatments were tough and fraught with a lot of side effects. And stigma and engagement still being issues that present themselves as barriers. So I think it's our job as health systems and healthcare professionals to really rethink how we're approaching how we achieve elimination to overcome what we would traditionally call system and provider barriers in order to get more patients engaged in treatment and cured. And ways in which this is already being done across the globe and here in the United States include co-location of hepatitis C services with behavioral health services, patient navigation programs, negotiation of lower drug prices, which we'll talk about some exciting things that have been announced with Michigan Medicaid, removing prescriber restrictions, broadening insurance coverage, moving treatment into the primary care space, supporting providers to do this and to have confidence in doing this, and really scaling up screening and treatment in harm reduction settings. So moving from epidemiology to talking about screening, the question often comes, who should get tested for hepatitis C? And this was recently updated almost a year ago this month. And it's now recommended that every adult, every person over the age of 18 get tested for hepatitis C at least once in their lifetime in the United States. Additionally, with each pregnancy, every pregnant woman should also get tested for hepatitis C. And this is also in addition to anybody who has ongoing risk factors. And certainly this includes persons who inject drugs. If that is an ongoing activity that patients are engaged in, they need to be tested regularly as part of that. So the U.S. Preventative Services Task Force, back in March of 2020, a little over a year ago, updated their screening recommendation so that they now recommend screening or testing for hepatitis C for all adults between the ages of 18 to 79 at least once in their lifetime. And this is really in addition to what the CDC now recommends and AASLD and IDSA, which in addition to the one-time screening, again, these agencies also endorse Hep C testing as part of routine prenatal care with each pregnancy, and then annual testing at least for persons who are actively injecting drugs, for HIV infected men who have unprotected sex with men because of the increased rates of transmission and risk, and men who have sex with men taking pre-exposure prophylaxis are also recommended for Hep C testing annually by the AASLD and IDSA. So this leads us to questions around how do we do testing? And testing starts with an antibody test. And here in the United States, that's still a blood-based test. An antibody test can have one of two results, reactive or positive, or negative or non-reactive. And in anybody who has a positive antibody test, this should ideally be coupled with what we call reflex testing to Hep C RNA. And the Hep C RNA is really the confirmatory test to tell you whether or not you have active infection. The Hep C RNA test is measuring your detection of virus in the blood. And there are a number of reasons why a person can have a positive antibody test. The most common reason is because of current infection or past resolved infection. So think of the antibody test as really a marker for present or past infection. Very rarely, it can be a false positive test. And again, if that antibody test is positive, it's recommended that all of these patients get a Hep C RNA test to measure whether or not there's virus persistent or present in the blood. And that is what really determines whether a person has active infection if that virus is present. Now, this concept of reflex testing means that antibody and the RNA testing should be one-step process, ideally, rather than bringing patients back for a blood test for the antibody. And if that's positive, then to contact them and bring them back for a second test. The ideal thing is to do enough blood tests so that if it's positive, your lab can then run their RNA without bringing the patient back for an additional blood draw. And if the RNA is not detected, that means there's no current infection and additional testing as appropriate. Again, for people with ongoing risk factors, they may need to get tested annually. And in those without any ongoing risk factors, additional testing is not recommended or needed. And for any of those patients who have detected virus in the blood, they have current infection and they need to be linked to care for treatment management, which for some patients may even include retreatment if they've known to have hepatitis C previously. And I think the key here where we still have room for improvement is with implementation of reflex testing. Again, how do we make antibody and that RNA testing a one-step process so that we don't have patients falling through the cracks between antibody testing and bringing them back for RNA testing, which happens still all too often. So what are the various tests we're talking about? There's the hepatitis C viral load, which typically becomes detectable 2 to 3 weeks after viral exposure. antibody test, which typically occurs 2 to 3 months after exposure. So you can see the RNA in the setting of infection will often, for immunocompetent persons, become detectable first. And we don't have any special test to determine acute hepatitis C infection. So the best laboratory evidence to support a diagnosis of acute infection is in somebody who has a positive Hep C RNA viral load test in the setting of a Hep C negative antibody test, because that tells you you're within that window period when the viral load is detectable and the antibody has not yet shown up. That indicates that this person is more likely to have acquired the infection recently or have acute infection. The other way in which acute infection can be inferred, or for which we have the best laboratory evidence, is in somebody who had a positive Hep C antibody test after a previously tested negative antibody test. So where you're going from negative to positive with an antibody. So again, indicating you might be in that 2 to 3 month window or period of recent infection. Now, laboratory-based diagnosis of acute Hep C infection is most straightforward when there's been a discrete known or suspected exposure. When a patient comes and says that they've had new onset or a change in drug injection practices, could be an example of this. Or if somebody tells you that they've had a percutaneous needle stick exposure to Hep C infected blood. Other scenarios might include things like a potentially non-sterile tattoo or a sexual contact with somebody with known Hep C infection. And in these patients, it's recommended that a baseline Hep C antibody and RNA testing is performed within 48 hours, ideally, of that exposure to document what their infection status is at baseline. And then in those patients who have this discrete recognized Hep C exposure, there's an algorithm in terms of when to repeat testing, typically within 6 months, to assess for whether or not they have new infection with both an RNA test, so the viral load test, and the antibody test. So when you have a discrete recognized exposure, check them immediately for antibody and RNA to know what their baseline status is, and then follow them for 6 months to see whether or not the RNA becomes positive and or antibody. So again, interpretation of these blood tests for acute infection, what you'll most classically see, again, the antibody may take up to 2 to 3 months to become positive. So it merely may be, the antibody test may be negative during the first 6 weeks after exposure. And remember, the antibody alone, the presence of it doesn't distinguish between acute or chronic infection. We don't have a blood test to tell us whether or not this is acute infection for sure. So we infer it based on the pattern of serologies. The Hep C RNA in the acute infection phase in the first several weeks typically will have wider viral load fluctuations. And so if you see, you bring a patient back for repeated viral load testing and you see the fluctuation of the virus count by more than 1 log IUs per ml, this could suggest or help support acute infection. And one thing to be very cautious about in the acute setting, Hep C RNA may be transiently negative because of these acute fluctuations during acute Hep C infection. So it's really important that the patients are followed out for up to 6 months to make sure that the virus remains negative at 6 months to know whether or not that discrete exposure, potential acute infection, has cleared on its own or not. Now remember that 15% of people will be lucky and clear this virus on their own. So the vast majority of patients will go on to develop chronic infection once they acquire this. And the other clue in terms of acute Hep C and blood test changes is fluctuations with ALT. And this could be, seeing very high and then low and then high ALT readings on serial blood tests. Again, could help support the diagnosis, but none of this by itself is diagnostic of acute infection. So we talk about the cascade to cure, because now we have curative therapies for hepatitis C. And it's really our job to work with communities that are at risk, to move them along every step in this process to get all of the patients who are living with Hep C treated. The 2020 standard of care is test everybody at least once in their lifetime, test people who are pregnant with each pregnancy, and test people with ongoing risk factors regularly, and anybody who is found to be living with hepatitis C should be offered treatment. Now, the reality is that there's a considerable drop-off of people between each step of this cascade to cure. So we, unfortunately, for a lot of reasons, lose patients between screening, diagnosis, evaluation, treatment, and cure. And so all efforts need to be put behind moving patients who are screened all the way down through treatment if appropriate. And the unfortunate reality is that low rates of diagnosis result in even lower rates of treatment. And this is the practical problem in terms of how we move the needle in terms of achieving elimination in the United States and elsewhere. And there's certainly, as I mentioned earlier, a number of barriers or gaps in care. And so starting with improved access to testing, bringing testing to where target populations are engaged in is very important first step. And then moving patients along by coordinating their care, co-locating care, integrating care into spaces where these people are already engaged. And there's certainly been a lot of innovations in Hep C diagnostics. Innovations have included this concept of coupling antibody testing with reflex RNA. So doing all of this blood draw in one shot instead of bringing patients back twice. And it's done through one venipuncture. It can be done in hospital and outpatient settings, working with local labs. And this also then gives you the opportunity, once you have the test results back, to not just tell a patient they have antibody and they may or may not have active infection, but to actually inform them and engage them around whether or not they really do have active infection or not. And that can influence engagement and care. Additional innovations include dried blood spot RNA testing. So this would involve finger stick for whole blood applied to filter paper cards. And this allows us to circumvent the need for having a phlebotomist and avoiding a full venipuncture, and the need to separate plasma at the time of processing the specimen that we get through venipuncture. The cold chain is also not required. And the cons here are the time to run the test can be variable. It's not a rapid test. So the card is dried and then sent to a lab and then processed. And so, so sending it to the centralized lab is still needed. But one of the benefits is a smaller sample is needed, and you don't need the skill and expertise of a phlebotomist and putting a patient through a venipuncture. There are point of care antibody tests. This is offered as blood, serum, and oral that can take 20 minutes. So these are really point of care rapid tests that avoid venipuncture. The oral test is approved in certain parts of the world. And co-infection with HIV may lower the sensitivity of this test, but it's a rapid test. Within 20 minutes, you can tell a patient whether or not their antibody is positive. And then finally, there is studies looking at and scaling up in parts of the world point of care RNA or viral load testing. It takes longer time, about 105 minutes, but a drop of whole blood is used to then to detect the presence of virus to inform a patient of whether or not they have active infection. And again, you can already tell, like, having the availability of point of care antibody and RNA testing can be really helpful for engaging patients on the spot or in a short period of time and getting them transitioned into care sooner. So this is a really nice review that Dr. Jason Grebely and others put together on how we really need to move over time from this multi-step process between antibody testing, doing a phlebotomy, receiving a diagnosis, doing confirmatory testing, to trying to do as many things as a point of care rapid antibody point of care test so that we can start treatment sooner. The more steps we have in this process, the more drop off we have in patients getting to the step of starting treatment and achieving a cure. So globally, when we think about innovations in macro elimination, there are some countries that are really leading the way in terms of achieving elimination goals. And key elements that are shared by countries that are really making substantial progress around Hep C elimination include, certain key elements that include a national strategy, usually bipartisan support or partisan-free political support around this issue, have really competitive drug pricing so that price and barriers to prescribing are not there, expanded universal coverage for Hep C treatment, rapid or quick antiviral initiation, such that some countries you can go to the local pharmacy and pick it up the same day as you're prescribed the treatment. Integration of point of care and rapid diagnostic tests in the process. And then embedded within this are what we call micro-elimination efforts, real funding to achieve these elimination efforts, elimination of all the prescriber, fibrosis, and substance use restrictions that still plague many parts of the United States here with payers, and really this concept of decentralizing testing and service delivery. So the expectation shifts from patients being expected to come to us rather than shifting that away from that to taking testing out to populations that are at risk, bringing treatment and service delivery out to where patients living with hepatitis C are. And engagement of primary care general practitioner expansion role in doing the treatment, that specialists are not required or needed in this process like they were many years ago when treatment was very different. So what do we mean by micro-elimination efforts? Well, we know that within populations, there are persons who are at higher risk for hepatitis C infection. This includes persons who inject drugs, persons involved in correctional facilities, and women who are pregnant. And so focusing additional efforts in terms of national and global innovation in these what we call micro-elimination populations is really key to how, again, you hone in and tailor services and get increase in treatment and cure in these populations. So we think about also spaces to build trust in persons who are at risk or living with hepatitis C infection. And going back to the concept of meeting people where they're at and not leaving them there, but bringing treatment to spaces where we are practicing harm reduction and supporting harm reduction practices. And here in the United States, this includes medication assisted treatment programs, syringe access programs, and in other parts of the world, certainly drug user health hubs and safe consumption sites, which are evolving here in the United States as well. So thinking about how we integrate and bring Hep C treatment and screening and management to harm reduction services is an important part of how we're going to achieve elimination. So HHS is currently mapping hepatitis C elimination projects across the United States. So this is a bit dated, and now Michigan will be joining this map given the recent announcements. When you look at the rate of reported acute Hep C cases by state, Michigan still has a pretty substantial number of new cases compared to the overall rate of acute infection that we see across the United States. So Michigan is actually above the national average in terms of the number of acute Hep C infections that are being diagnosed and reported to the CDC. And certainly there are a lot of opportunities in Michigan for viral hepatitis elimination. And it does feel like a very exciting time to be here because of the engagement and efforts by the Michigan Department of Health and Human Services, along with many providers who are looking to move the needle in terms of overcoming barriers to treatment and cure. And as of the end of 2019, there were over 137,000 unique individuals reported as a Hep C case in the state. 50,000 had a known positive viral load. And so this gave us a little bit of a sense of how much Hep C prevalence as of over a year ago we had. And this also takes into account, though, that we may be still suffering from a large number of patients who are not yet diagnosed. And so screening efforts are really a critical piece to what we're doing here in Michigan. So just a few weeks ago, April 1st, the Michigan Department of Health and Human Services Viral Hepatitis Unit announced some very exciting changes around Michigan's state plan on eliminating hepatitis C. So they launched the We Treat Hepatitis C initiative. And it's really a state plan aimed at eliminating hepatitis C. And there was a nice press release, and essentially a key component here to what was announced was the elimination of prior authorization requirement for the preferred pangenotypic MAVERIT DAA treatment. So they did a competitive call for pharma applications for pangenotypic regimens, and they just announced a couple of weeks ago that MAVERIT is going to be the preferred pangenotypic option that will no longer require any prior authorization. And what this also means is that there's removal of prescribing restrictions around sobriety and drug use, as well as the need for consulting with a Hep C specialist. So again, this is really welcome news because these efforts are needed to try to scale up treatment, and removing these barriers are an important key part. And because of these exciting changes, the grade from the stateofhepc.org, which is a national effort to try to grade states in terms of Medicaid access to hepatitis C treatment, Michigan now went from an A- to an A+ with removal of these restrictions and these announcements. So there certainly are still opportunities to scale Hep C screening and treatment and harm reduction programs. And we know that there is some testing going on, but certainly room for additional scale up to identify patients who are at risk for living with hepatitis C, and then transition people identified as living with hepatitis C into care. So the Michigan Opioid Collaborative is integrating Hep C services in the last year of their program, and this includes submitting Hep C cases to be discussed. We actually now have a bi-weekly Friday morning case consultation program where providers are welcome to join, submit cases, discuss cases. A lot of this is learning from one another. I, as a hepatologist, I'm learning a lot more about opioid use disorder and patients in different practices in different parts of the states. And the second component to this is this 3-part webinar series that will be archived and available on demand for continuing education credits. So we are currently working with over 5 different sites throughout the state of Michigan. And in the first 6 months of the program, have already discussed around 50 cases, and a third of these cases have now been initiated on treatment, and 2 have already achieved a cure. So if you're interested in learning more about hepatitis C, how you can learn to do more around diagnosis and treatment, we'd be thrilled to work with you. So feel free to visit our website where you can navigate under the About MOC services to hear a little bit and learn a little bit more about what we're doing and connect with us. We'd be happy to hear from you and work with you. And with that, I'm going to end there. Thank you very much.